Welcome. This presentation is going to be a brief introduction to the SARS-CoV-2 virus, which causes the disease COVID-19. My name is Dr. Terry Redman. I'm Associate Dean for Academic and Faculty Affairs, Director of the Institute for Biosecurity, and a professor in the Department of Epidemiology and Biostatistics in the College for Public Health and Social Justice here at SLU. So in this presentation, I'm going to briefly discuss the high-risk groups related to COVID-19, talk about how COVID-19 is transmitted from person to person, define what it means to be exposed to COVID-19, and then lastly talk about mask use and physical distancing measures that are implemented on campus this fall. Coronaviruses are respiratory viruses that were first identified in the 1960s. They're named after the crown-like spikes on their surface. In Latin, the word corona means crown or halo. Now, most human coronaviruses circulate every year and cause just a mild respiratory illness that's similar to a cold. However, we have had 3 novel or new coronaviruses that have emerged since 2002. There was SARS coronavirus 1 in 2002, the MERS coronavirus in 2013, and now SARS-CoV-2, which causes the disease COVID-19 that appeared in 2019. These novel coronaviruses have caused much more severe disease than the coronaviruses that circulate each year. Most infected individuals, about 80% of them, will have a mild illness. But about 15% of people who are infected will require hospitalization, and about 5% will need intensive care in a hospital. Now, in contrast, only about 1% of people who are infected with flu usually require hospitalization. So COVID-19 is a much more severe disease compared to influenza. Adults, especially those that have comorbidities and those who are over the age of 65, are at higher risk of severe disease and death. Those with comorbidities have a mortality rate that's closer to about 10%, and those who are over the age of 70 have a mortality rate between 8 and 15%. Children tend to have much more mild disease than adults. Fewer than 1% of infected children usually require hospitalization. Mortality is also affected by the healthcare surge in a community. When a healthcare system's capacity is exceeded by infected individuals who need medical care, we see our mortality rates increase. That's why it's really important that we try to keep the number of infected individuals low so we can keep the number of individuals who require hospitalization low. As we often see with infectious diseases and other health issues, COVID-19 is disproportionately affecting non-white individuals. As you can see on this slide, American Indian, Alaska Native, Black, and Hispanic individuals are significantly more likely than Asian or white individuals to be hospitalized with COVID-19. History shows that severe illness and death rates tend to be higher for these populations during public health emergencies, and we are seeing that with COVID-19. Now, we don't have accurate data on all COVID-19 related deaths in the United States, but when we look at all of the existing data, Black Americans are 2.4 times more likely to die from COVID-19 than the general population. African Americans and people with lower incomes are disproportionately infected with COVID-19, and they're more likely to die from the disease. Health differences between racial and ethnic groups result from inequities in living, working, health, and social conditions that have persisted across generations. It is really important to keep these high-risk individuals in mind when we think about how we safely reopen our college campus. Even though most of you are going to fall under the category of being at low risk from severe disease, some of you have underlying health conditions that can put you at risk from severe disease. And in addition, some of you may live with family members who are older, have underlying illnesses, or have other factors that put them at risk from severe illness or death. We have to consider the health and safety of our faculty and staff, as well as just the students, and also the greater community of St. Louis. And many faculty and staff at SLU are people of color, older, and/or fall under the high-risk categories. So now let's talk about how COVID-19 is transmitted. But first, just a quick disclaimer. One of the challenges in responding to an emerging infectious disease is that we don't know exactly how that disease is transmitted until we have collected sufficient data about that disease. And we are still learning about the SARS coronavirus 2 virus. But based on what we know so far, the virus is believed to spread to close contacts primarily through respiratory droplets when an infected person coughs or sneezes. And individuals are believed to be the most contagious when they have symptoms and when their symptoms are the most severe, when they have a fever and when they're coughing. But we do have some studies that have found that individuals can shed virus a day or two prior to symptom onset. We don't know exactly when individuals first become contagious, but as I said before, we believe that infected individuals are likely to be most contagious when they have symptoms. There's also evidence that there's an increased risk of virus spread during what we call aerosolizing procedures, and these are procedures that generate infectious aerosols. But these are only created from medical procedures that would take place in a hospital or a healthcare setting. We do have some very limited evidence that a person could get COVID-19 through contact with a contaminated surface, but this is not believed to be the main way that the virus spreads. Current evidence suggests that SARS-CoV-2 can remain viable for hours to days on some surfaces, but the infection transmission risk related to this is unclear at this time. Just because an organism can survive on a surface doesn't necessarily mean that it poses an infection risk to other people. That pathogen has to have a way to move from the contaminated surface into the body of a susceptible person, and there has to be enough virus there to cause an infection. So just because a virus is detectable on a surface doesn't necessarily mean there's enough there to actually make someone sick. So although pathogens on hard surfaces pose a theoretical infection risk, we just don't know for sure at this time exactly how risky it is. But because there is that theoretical risk, the CDC suggests disinfecting surfaces correctly and frequently, and then to always perform hand hygiene after touching surfaces that may have been touched by an infected person. You are going to see staff doing a lot of cleaning and disinfection on campus, and disinfection materials will be made available in classrooms and other parts of campus, so you may disinfect your own environment if you feel the need to do so. So now let's talk about the definition of what it means to have an exposure to COVID-19. You have to have close and prolonged contact with an infected individual when not wearing personal protective equipment in order to qualify as having an exposure to COVID-19. More specifically, this means being within 6 feet of somebody who's infected for 15 minutes or longer when you're not wearing a mask. Alternatively, it could mean having direct contact with the respiratory secretions of an infected person. So for instance, if you did not have your mask on and somebody coughed directly on you, you wouldn't need to have 15 minutes of contact in order for that to qualify as an exposure. So there are a number of ways and interventions that we put in place to try to control pandemics. One way is screening individuals for potential illness and then placing them into isolation if we believe that they are infected or if we have confirmation that they are infected. In addition, we do contact tracing. So once we identify that somebody is infected, we trace back everyone with whom that individual has had contact so we can monitor those individuals for illness. Individuals that are found to have had contact with an infected individual are placed into quarantine. For some pandemics, we have a pharmacological intervention, meaning that we have a pandemic vaccine or a medication that helps to prevent illness or to decrease the risk of death. At this time, we do not have a pharmacological intervention for COVID-19, but there is hope that we will have a pandemic vaccine in the next couple of months. In addition, one of the primary ways that we try to control pandemics is to implement what we call the non-pharmacological interventions, or NPIs. These include all of the interventions that are wrapped up under the category called social distancing. This includes things such as canceling public gatherings, physical distancing, like I mentioned before, keeping 6 feet between you and other individuals, having individuals work from home or telework as much as possible, and then also mask use in public. During pandemics, the CDC and public health officials sometimes ask members of the general public to wear a face mask while they are in public or when they need to be closer than 6 feet away from others. If a person infected with COVID-19, regardless of whether or not that person has symptoms, if they are not wearing a mask, they are expelling a lot of infectious particles into the environment. If an uninfected person is wearing a face mask, that mask will provide them with some level of protection against exposure to those respiratory droplets. If a person infected with COVID-19 is wearing a face mask, that mask is going to block many of the respiratory droplets from being expelled into the environment, although some will still get through or around that mask. So this provides a fair to large amount of protection to the uninfected person, even if they're not wearing a mask. But if both the infected person and the uninfected person are both wearing a face mask, this will provide the largest amount of protection against the spread of respiratory droplets. But it's important to remember mask use is only one intervention or protective measure. It's also critical that individuals try to maintain at least 6 feet of physical distance from others as much as possible to further reduce the risk of disease transmission. In addition, SLU is implementing other protective measures to keep us as safe as possible. So this includes things such as increasing environmental cleaning and disinfection, having those on campus conduct regular health screenings, and other measures. One of the single most important things you can do to try to prevent yourself from becoming sick is to perform hand hygiene. Hand hygiene consists of either washing your hands with soap and water for at least 20 seconds or the use of an alcohol-based hand sanitizer. Hand hygiene will work really well as long as you do it consistently. It's really important that you do perform hand hygiene after you touch any area of the environment that potentially could have been contaminated and before you touch your eyes, your nose, or your mouth. That ends my brief summary of COVID-19 and some protective measures that will be used on SLU's campus this fall. SLU is dedicated to making campus the safest environment possible for all of us, so that we may continue to pursue our education and conduct research. Please remember, we need to follow the public health safeguards not only to protect ourselves from disease, but also to protect our friends, our family, our colleagues, and community members, many of whom are at high risk of severe illness or death.